So, sir, we will start.
Yes, sir. Yes, sir. Please, sir.
Good evening to all and welcome to all to my dear students and as well as today's presenter, that is Abhijit from the Jubilee Medical Trichure. I'm also welcome to our stalwart, that is Dayananda sir. Is one more crown over him, that is he already present with one book, Clinical Pulse Surgery, and second edition of the PICE Surgical Handicrafts. I think
Surgical handicrafts.
They said getting branded. I advise all my students of PGs to buy one surgical handicrafts, but other PICE surgical hand is now also outdated nowadays, not latest. So, sir is present with the latest surgical handicrafts, and I also booking one personal copy for me as well as for the department. I think this will do very excellent book by sir. And for PGs, Clinical Surgery Pulse is an excellent book. Just before their breakfast, the morning day of the surgery, is the only book reference the morning day of practical examination, not the daily, not the measure, but you can have a copy of Pulse and everything in that. That's an ideal book for reference for the students on the day of the practical examinations. So I am welcoming Dayananda sir as the evaluator. He's a stalwart and is a great teacher of surgery department. That's an entire Kerala, and is gifted with so many students inside and outside India. I also are welcoming another our former HOD, our great teacher of
Namaskaram, Rajan sir. Rajan sir, namaskaram.
Ryan sir is not joining.
Good evening, sir.
Yes.
Ryan sir, good evening, sir.
Good evening.
Good evening, sir.
Ryan sir is both Ryan sir and Dan were spending their time with us, evaluating the program. And every attractive part of this program is the take-home message is words of Ryan sir and 10 commands by the Dayananda sir, and everybody appreciated. That is a very active part or attractive part of this program or Kerala Surgery Preeti Clinics is their presence, their great presence. I also welcome today's examiner, Sir Chandra, the HOD of the JSS Medical College, Mysore, and Sadish Prabhu from Kalanjeri Medical College, and Alexis, some problems, is not joined. And also our my friend Srinivas from Coimbatore.
Yes, sir. Thank you.
So without losing much time, we'll go to the presentation. That's Abhijit, you can start. Abhijit from Jubilee.
Good evening, respected teachers. Sir, am I audible in this?
You're audible, pa? You tell from which college? Who is your
clear? Not clear.
Not clear. Which college? Who is your HOD? Who is your guide?
What happened,
On the screen.
Yeah, your screen sharing is not there.
Yeah, the screen sharing has not come yet.
What happens? Cancer vaccinated?
Yes. No problems.
No fever, no headache.
Did not even take paracetamol.
Malaki povununda, sir? Malaki povununda?
Illa. Summa.
That's kind of
Not for validity.
Oh, that's right, sir. I didn't see that slide.
Yeah, the side is quite clean.
It looks stylish.
Abhijit, some.
Sir,
Screen is not visible, Abhijit.
I had a long tenure at Sabarimala.
Yes, sir.
At 36 years I've gone.
Oh, very good, sir. Double Gurusami.
Yes, they were good Swami.
That charm has gone, sir. The way, the
Now
time you went, it was full of kallum mullum.
Yes, yes. Now it's gone. It is easy climbing, you know.
Now it's easy climbing.
It is just like,
No kallimulli, concrete steps.
yeah.
Good God. Abhijit,
The whole thing looks like a ramp,
Yes, sir.
a ramp walk. Indipatti Abhijit,
അഭിജിത്തിന്റെ കറങ്ങിക്കൊണ്ടിരിക്കുന്നുള്ളൂ.
is it visible now, sir?
Yes. Not visible, pa.
yeah, the screen is not visible and your voice is breaking, Abhijit.
Sir.
And you can try again, no problem.
Sir.
Fading picture. Range ಇಲ್ಲ ಸ್ವಲ್ಪ ready. Some problem with the connection. The connection range ಇಲ್ಲ, there is no range. സാറിന് പറയുന്ന ഒടുവിലല്ല. Ready.
Sir, am I audible now, sir?
Yes, pa. Yeah, you make it full screen.
The screen is okay.
Sir, I think when I'm trying to connect my video, my net is getting lag, sir. Can I continue with this presentation?
No, you can close your video, share the screen.
Sir, whether the screen is visible, sir?
No.
No, Vijay.
Oh, okay. Now I'm good, sir. Sir, if you-
Abhijit, you are not properly audible.
Abhijit, shall I try to share it? Vijay?
Slow, very slow. Can you say 15?
Obi.
Sir, no.
No, no, no. Now it's on the screen.
No, I am sharing it, sir.
Yeah,
Now
okay.
it's
I am sharing it.
Very good.
Abhijit.
Yes.
Sir, sir, am I
No,
audible now?
you're audible, but your screen is visible.
Yeah, now it is. Now it is. Yes.
Abhijit, start.
Sir, may you please switch off my video because net
Yeah,
is
please,
slowing.
please.
Sir, can I start now?
Yeah, you start.
Please do.
Good evening, respected teachers. Myself, Abhijit, final year junior resident from the Jubilee Mission Medical College in Thrissur. And this presentation is done under the guidance of Dr. Ashok, who is the professor and HOD of our department. Moving on to the case, it's a case of a 54-year-old gentleman who comes from
The voice is breaking.
Sorry.
I think you can take off use the computer mic for the headphones you can take off.
who belongs to upper middle class family. He presented to the OPD with complaints of
Yes.
He presented to OPD with complaints of swelling in the right groin since last 3 years and pain in the right groin since last 6 months. Moving on to history of present illness. Patient was apparently normal 3 years back when he started noticing a swelling in the right groin region, which was initially small in size that gradually progressed to the present size. Swelling increases when standing, coughing, and lifting weights, and it decreases on lying down position and disappears on manipulation with fingers. He also complains of a dull-liking type of pain in the right groin since last 6 months that increases while straining and relieves on lying down position. There is no history of any abdominal pain, abdominal constipation, or acute acute onset severe pain of the swelling or rapid increased rates of the swelling, fever or weight loss. There is no history of any swelling in the left groin or any other sides.
Answer.
There is no history of any chronic cough. There is no history of any chronic constipation. There is no history of any increased frequency, urgency, nocturia, dysuria, poor stream of urine, and straining to void or hesitancy. Moving on to diagnosed to have diabetes mellitus and hypertension since last 4 years, and he's on treatment. A diagnostic case of coronary artery disease, which was diagnosed 3 years back, and currently he is on dual antiplatelets, and he also underwent percutaneous transluminal coronary angioplasty 3 years back. There is no history of any pulmonary tuberculosis in the past. There is no history of any abdominal surgeries in the past. Personal history: he was a smoker who was stopped smoking 3 years back following coronary artery disease event, and he smoked 1 packet of cigarette per day, which was for approximately 20 years, which gave a pack years of 20 pack years. And he was also an alcoholic who stopped alcohol consumption 3 years back. His sleep and appetite is normal. He consumes a mixed diet. Moving on to family history, he is the second child of a non-consanguineous couple. His mother expired of old age. He has 2 siblings and he got married and has got 2 kids. There is no history of any similar illness in the family. On treatment and allergy history, he is on regular treatment for coronary artery disease, diabetes, and hypertension. And there is no history of any documented drug or dust allergy. Moving on to examination. Examination was done after getting an informed consent, and patient was examined in a well-lit room with adequate exposure. On general examination, patient was well conscious, oriented to time, place, and person. His body mass index was 25 kilogram per meter square. His pulse rate was 86 per minute, which was regular in rhythm, normal in volume. Character of the vessel wall and condition of the vessel wall was all normal. All the peripheral pulsations were felt. Blood pressure was 136 or 86 millimeters of mercury, which was measured in the right arm in the supine position. His respiratory rate was 18 per minute, which was abdominothoracic, and he was afebrile at the time of examination. His Karnofsky performance score was 100. There was no pallor, tearus, cyanosis, clubbing, lymphopathy, or his head, skull, and gait was normal limits. Which is done and supine, exposing from umbilicus to well. On inspection, there is a single oval swelling of 8 into 5 centimeter on the right inguinal region, confined above and middle to the pubic tubercle, extending down to the root of scrotum. And the surface of the swelling appears smooth, skin of the swelling is normal, and the swelling expands on coughing. There is no visible peristalsis of the swelling. And the of 3 to 2 or the left inguinal region, which is also confined to above and middle to the pubic tubercle, with smooth surface which expands on coughing. Skin of the swelling appears no. Scrotum.
You're not audible. Vijay? No, either your mic is not good or the connection is not good. Abhijit?
Sir, audible?
Yeah, you remove the headphones, but you talk over the mic itself.
Sir, is it clear now?
No, sir, is it breaking? No, sir?
Yeah, it's breaking.
It's breaking, but you have a good connection.
No, sir.
You speak, let us hear.
Sir, is it okay now, sir?
Not breaking. Are you using the headphones?
Surface of the swelling appears smooth, distances of the swelling. another single overs on inspection. They have this
No, Abhijit. No, it's breaking. It's breaking. Not. It's not audible. Not.
There is another single over of the left inguinal region into the circle. It has smooth surface filling appears normal. Velocity and appears normal. Is it okay now, sir?
No, Abhijit.
Abhijit, you should have practiced for the net connection before coming to present a national, like a national forum. Yeah.
So it was actually tried, sir. It was
now
okay. Fine.
Now it is good. Now it is good. Now it is good.
Sir, can I continue now?
Yeah, please. Remove the headphones, switch off the video, then present. Yeah. Now
sir, can I continue now?
Yeah, please, please.
His scrotum.
Isn't it? Gopi?
So Gopi sir is in the phone.
Okay, okay.
Your palpation.
Yeah, okay, fine.
Moving on to palpation, there is no local rise of temperature or tenderness. On palpation, there is a single overt swelling of 18 to 5 centimeter is palpable over the right inguinal region, which is above and medial to the pubic tubercle, not extending into the scrotum. All borders of the swelling were well defined and the surface appears smooth on palpation. Swelling is soft and elastic in consistency, and the swelling is reducible manually with a gurgling sound. There is another reducible swelling of 3 into 2 centimeter palpable over the left inguinal region, above and medial to the pubic tubercle, which is also soft and elastic in consistency. Expansile cuff impulse was present bilaterally. On deepening occlusion test, swelling reappears on both sides, and on doing Siemens test, impulse was felt over the left middle finger on both sides. Scrotal examination is within normal limits and the testis is normal. Penis is central in position, it is circumcised. Meatus is normal and there is no discharge. Urethra examination showed normal appearance without any strictures. There is no inguinal lymphadenopathy on either sides. And both inguinal swellings were resonant on percussion. There was no bowel sound heard over the swelling. On examining the tone of abdominal muscle, there was no undue protruding of lower abdomen on standing position. There is no malgagnian bulges seen, and tone of abdominal muscle appears normal. On digital rectal examination, there is no fissures or sentinel pile. Anal tone appears normal. There is no growth, no prostatomegaly. Other systemic examination showed respiratory system showed a clear chest with bilateral normal air entry and normal vesicular breath sounds. There is no added sounds. S1, S2 was heard normal. There is no murmur. Per abdomen was soft, non-tender. No mass was palpable, and there was no free fluid. Central nervous system examination showed a normal higher mental function with a normal sensory and motor system examination finding. On summarizing, it's a case of a 54-year-old businessman who is a reformed smoker and alcoholic, and who is a non-case of coronary artery disease, diabetes mellitus, and hypertension, now presented with progressively increasing swelling over the right inguinal region since 3 years, associated with a dull-liking pain and discomfort since last 6 months. On examination, general examination showed a stable vitals. Local examination showed a non-tender, smooth, reducible swelling above and medial to the pubic tubercle on both inguinal region, more on the right side with a expansile cuff impulse and negative deepening occlusion test, and cuff impulse on middle finger with a Siemens test on both sides, and other systemic examination with the normal limits. So by that, I would like to give a diagnosis of bilateral incomplete reducible direct inguinal hernia, more on the right side with intestine as content without any complications.
Now we wait to go to the examination. Srinivas sir.
Yes,
sir. Am I well audible now?
You're audible. You're fairly good presentation except for the slides. And there is a lot of some of the typing mistakes is there, testis spelling is there. And straight away, I do not know whether my senior examiners will you say straight away the patient has got a swelling in the right groin or in the right lower abdomen, which I do not know whether. Can you use that word now, sir? Babu sir?
Babu sir will end of the section.
Okay, sir. That's my thing. Can you say swelling in the right groin? Can the patient's own words, what is the thing? But I do not know what the other examiners feel. That is one thing which you said. Otherwise, Sir, you can take over, sir. Sir, from this we can join together.
Sir.
I think you can use the term groin, inguinal, say lower abdomen. They come in our part. What people they come with Tode Sandhi. That means groin in Kannada.
Sir, your voice also not
your voice
audible,
not,
sir. Not clear, sir.
Not clear, sir.
you can take.
Now, hello.
Yes, sir.
Now
Yes,
it's
sir.
okay. Now it's
Now
okay.
it's okay. So in this part, people usually they come with complaints of swelling in that junction of thigh and the abdomen, what we call Tode Sandhi, and that's what that is referred to groin. That can be accepted, sir.
Okay, sir. Okay, sir.
Okay. Sadish ji, Prabhu. Sadish.
What happened to him?
Hello, Sadish ji.
Unmute, sir.
I unmute.
Yeah.
Groin is acceptable. It was a good presentation. I think the word groin is acceptable. Only thing is you should not use inguinal region.
Yeah.
So I think groin is acceptable.
Okay, sir. Okay, sir. Okay, you said patient was apparently normal. Where did the swelling start? From above downwards, or that is what you missed in this one? When did it started swelling in the right groin region, and it's initially small, progress to the present size? Is it coming from above downwards?
Sir, it is coming from above onwards.
You are not mentioned it.
Yeah.
Is there any difference in it?
Yes, sir. Usually, inguinal swellings will be coming from upwards and descending downwards.
Yeah, so swelling
But if it
started
is
from
pure
above
scrotal swelling,
downwards.
it will start from below.
Swelling increases when standing, coughing. It may decrease on lying down and disappears. Yes. Sir, Sharath, sir, you are anything? You can you go to the next slide? Satish, sir.
I think in the history of present illness, I mean, do you feel that you should include something else other than the urinary symptoms? Being a middle-aged man, 54 years, and we are supposed to inquire that, especially when you are considering a hernia in the symptoms. Do not inquire about the bowel symptoms.
There's no stuff.
Yes, come to the next slide, sir.
Sir, it's the next slide.
What is this dull aching pain in the right groin usually due to? When you suspect it?
The pain is usually in the periumbilical and lower abdomen due to pull over the root of the mesentery.
Pull over the mesentery. Release on lying down. No history. We asked for abdominal pain, abdominal. He has asked Satish, sir.
My point is, should he not go into reference with the lower GI, that is altered bowel habits?
Sir, the next slide it's mentioned, sir.
You have mentioned it.
Yes, sir, there is no history of any constipation.
Okay, fine.
What is the importance of asking these lower urinary tract symptoms?
In patients with benign prostatic hyperplasia, they can present with lower urinary tract symptoms, and because of the constant increase in the abdominal pressure because of straining, these patients will be more prone for developing hernias.
You cannot say benign, you can say prostatic hyperplasia, prostatic enlargement. In this age, you can get even malignancy, isn't it? So benign is common, but prostatic enlargement, frequency, urgency, which is the first symptom you get in prostatic enlargement? Nocturia.
Nocturia, sir.
Anything in this slide, sir? Satish, sir.
Abhijit, if you inquire about
Yes,
weightlifting, a patient in weightlifting, what is profession?
Sir, he is a businessman by profession.
Any importance of weightlifting on the hernia development?
Yes, sir. Those who are having history of chronic weightlifting will have associated weakness of abdominal wall muscle, and they will be more prone for developing
Now that
hernia, especially direct
now
inguinal.
that
No,
theory
that has come
now
down.
that theory is out.
According to
Weightlifting,
latest Bailey, there is no proven evidence that weightlifting is no more evidence for
yes,
or a reason for development of hernia.
straining can the patient detect the hernia due to the straining, not the weighting. Like just whatever the obesity
Yes, sir.
and hernia. Obesity or hernia.
Sir, in
Obese
obesity,
patient
there will be excessive fat, adipose tissue accumulation within the muscle fibers that can cause weakening of the muscles.
that also not correct. That is the latest Bailey saying. The obesity is negative. BMI and the negative related to the hernia. Obese people
Yes, sir.
less compared to the thin patient, less hernia development. These are newer developments in hernia, but
Yes, sir.
smoking is still very important. Smoking produces
Yes, sir.
not the obesity.
Sir, smoking will causes interfere with collagen synthesis, especially type 1 and type 3, and also they interfere with the balance of metalloprotein synthesis turnover channels. So altogether that will causes weakening of the collagen or collagen synthesis. So they will be
You
also
ask
more
for
prone
a
for hernia.
history of surgery in the past.
Yes, sir. There is no history of any abdominal surgery, especially open appendectomy.
Okay, fine. Yes. Srinivas, can continue.
See, you said chronic cough and chronic constipation. Does it really produce hernia, or is it increases the what is the importance of asking? Is it important post-operatively or pre-operatively? Treatment
Sir,
of chronic
important
cough or chronic
both in
constipation.
it is important both in pre-operative and post-operative management. We have to optimize the cough pre-operatively itself before taking the patient for surgery. Otherwise, patients can develop post-operative recurrence of hernia. Similarly, constipation has to be evaluated, especially in an old age patient. Any other underlying cause for this constipation has to be ruled out.
What is the importance of abdominal surgeries?
Sir, abdominal surgeries like open appendectomy can cause injury to ilioinguinal nerve that can cause weakening of the abdominal wall musculature. So there will be more prone for developing
Does
hernia.
it lead to inguinal hernia, indirect inguinal hernia, or direct inguinal?
It will leads to direct inguinal hernia, sir.
Why not indirect inguinal hernia?
Sir, indirect is usually a congenital anomaly because of the presence of patent processus vaginalis, but direct is the one which is an acquired one that usually occur in the later terms because of the weakness of abdominal muscle.
Now, what happens to the ilioinguinal nerve when it is damaged outside the inguinal canal and inside the inguinal canal?
Sir, when it is downward damaged before the inguinal canal or outside the inguinal canal, it can causes weakness of the abdominal wall muscle. But when it is injured, because the muscular supply will be given before entering into the inguinal canal.
So what will happen if you injure the nerve in the canal?
Sir, when it is getting injured in the canal, only the sensory supply will be impaired. So there will be complaining, especially root of penis, the upper part of the scrotum and the superior medial aspect of the thigh.
In females?
In females also, it will be affecting the superior middle aspect of the thigh and the labia majora.
Right. Satish sir, please. Or Sarath sir, you can ask.
Hello.
Yes, sir.
What about on left side? This is about right side. Any surgeries on the left side that can lead to? Can you mention any surgery? Nowadays, it is not being done. It is taken over by the endo. That is the clue for you. Urologist, they are doing.
Varicocele surgery.
Not varicocele.
Varicocele.
Similar to appendix incision they do on the left side for what is that? Anything to do with ureter? Retrolithotomy.
Oh, okay, sir. Okay, sir.
Right. What is the point on the right side which you said appendix?
Sir?
What is that point on the right side called of appendix?
Sir, McBurney's point.
What is the same point on the left side?
Amoebic point.
Name the point.
Sir, amoebic point.
Amoebic point of? Since Sir said left side, I'm adding. See, postgraduate you should know. Amoebic point of Manzenberg.
Oh, okay, sir. Yeah.
You should. Right. First list, he said he's a smoker. Stopped 3 years back.
Yes, sir.
How does smoking predisposes an individual for hernia, man?
Sir, smoking will interfere with the synthesis of collagen, especially type 1 and type 3 collagen. Also, they interfere with the balance of the matrix metalloprotein breakdown turnover pathway. So that can precipitate weakening of the abdominal wall. And also it interfere with the postoperative wound healing. And these patients will be also having associated chronic bronchitis and chronic cough can be there. COPD will be there, sir.
Yeah. Why did you say it is hernia? What are the reason for the diagnosis hernia?
Sir, this patient presented with the complaints of swelling in the inguinal region confined to above and medial to pubic tubercle. And these two swellings were reducible swellings which showed expansile cough impulse. So the most likely diagnosis is inguinal hernia, sir.
You mentioned on our side that a ring occlusion is not done. Why?
Sir, ring occlusion test was done on both sides, sir.
Ring invagination.
Sir, only in ring invagination test I have not done, because I attempted, but it was painful, sir.
Show your slide. Show your slide. Invagination test on one not done. Mentioned.
Yes, mentioned, sir.
That is not invagination test.
Finger yes,
sir, it is finger invagination test, sir. Sorry, sorry, sir, typing mistake.
Ring invagination. Finger
sorry, that was a finger invagination test, sir.
Right, you have to spell it.
Why you are not doing nowadays?
Sorry, it's an absolute test now, and it is producing discomfort for the patient.
Discomfort for the patient. Okay, correct. You will do a ring occlusion test in this case.
Sir?
Ring occlusion test.
Sir, it's done on both sides. On doing on both sides, the swelling reappears. So it indicates.
You are given a choice of only one test to be done. What is the test you will do?
Zeeman.
Which is the confirmatory test?
There is a ring occlusion test.
Ring occlusion test. Now tell me, how do you occlude it? Where is the ring?
Sir,
in which part?
First I will make the patient to lie down. Sir, this ring is located 1.5 centimeter above the line joining anterior superior iliac spine and pubic symphysis. And I will be first making the patient to lie down and make sure that the hernia is completely reduced. Now I will be keeping my thumb over the deep ring and ask the patient to stand up by keeping the thumb over the same position. And on getting up, I will be seeing whether swelling is reappearing or not. If it is not appearing, I will tell the patient to blow with closing the nose, and will look for whether swelling is reappearing or not. If the swelling is reappearing, it indicates it's a direct hernia. It is not reappearing, it indicates an indirect one.
Where is the ring situated? Which part of the body?
Sir, it is a defect in the fascia transversalis. It's a U-shaped condensation of fascia transversalis.
Right. The external ring?
Sir, it's the internal ring.
External ring, where is the defect in which?
Sir,
where is the anatomical landmark of the external ring?
Sir, it's a defect in the external oblique aponeurosis, which is located just above and medial to pubic tubercle.
What is the shape of the external ring? What is the shape of the internal ring?
Sir, external ring is a triangular slit, whereas internal one is a U-shaped condensation of the fascia transversalis.
Right. I occlude the ring, but the hernia comes out. What are the fallacies of internal ring occlusion test?
Sir, sometimes there can be a widened internal ring. So in such case, even if it's a direct hernia, indirect hernia, on doing deepening occlusion test, swelling can reappear. Also in pantaloon hernia, like dual hernia or a saddleback hernia, even if one component is occluded, the other component can reappear.
Improper occlusion.
Yes, sir.
Improper occlusion is one. Number two is the ring is more widened than your thumb. And the third one is a pantaloon hernia. Okay.
Yes, sir. Okay, sir.
Sir, please, Satish sir or Sarath sir.
Yes, Abhijit,
sir.
Your presentation was very systematic, the examination findings. Now, whenever we present something, we should have a clear idea why we use that. Now, I mentioned about the expansile swelling. Now, what does you mean? What do you mean by exactly by an expansile impulse on coughing? What does
Sir,
it suggest?
expansive swellings means these are swellings that will disappear initially, but will need some external force or a opposite force to make it to reappear again.
So that is a reducibility, no?
Expansive.
Expansive.
You are telling the explanation for
Expansive,
reducibility.
when we are keeping two fingers over that, asking the patient to make a or give a force, that finger will get separate each other.
Why does it happen? I am asking because this is one of the findings which suggested an uncomplicated hernia.
Yes, sir. On rising or on increasing intraabdominal pressure, there will be more increase in the content. So that will leads to separation of the
How will you do
fingers.
that test?
That's one point.
How will you do that?
Sir, sir, I'll be keeping two fingers, the thumb and the index finger, over the swelling and ask the patient to cough. And if the finger is getting separated, sir, it is anteriorly and ring finger index is posteriorly.
What is the position of patient? Lying down, standing.
Patient is in the, sir, is in the standing position.
What are the tests you conduct in standing position in the hernia?
Sir, pardon, sir.
What are the examination in a case of hernia in standing position?
Sir, deep ring occlusion test, Zeeman's test. Deep ring occlusion test, Zeeman's test.
Anything else?
Eliciting expansile cuff impulse.
Examinations. Measurement of the hernia in standing position.
Okay, sir.
Again, the percus, metal percus in again the standing position. The content will come down.
Yes,
okay. Sadish, we can continue.
Yes. Abhijit, yet another point. You mentioned about the ring occlusion test. Where exactly will you look for an impulse? Suppose you are not feeling it with a deep ring, obviously you will be seeing it, looking at the impulse. Now, I don't think that you have mentioned where you exactly saw the impulse or you found the finding. In other words, what's the margins of the boundaries of the Hazelback's triangle?
Sorry, it will be lateral to boundaries will be medially it is bounded by the lateral border of rectus abdominis, laterally by the inferior epigastric artery, and inferiorly by the inguinal ligament. Direct hernia will be medial to the inferior epigastric artery, and indirect one will be lateral to inferior epigastric artery. So on deep ring occlusion test, you must felt lateral to inferior epigastric artery.
Abhijit, okay, continue. Sadish, you can continue. Continue.
So, what does it suggest? You are saying that you look for the impulse lateral to the ring, is it? Deep ring, or is it medial?
Lateral to inferior epigastric artery, and I'll be checking for.
So
and the pulsation will be felt on the medial.
Right. So that suggests that the hernia is a direct or indirect.
Which one, sir? If it is felt lateral to inferior epigastric, it is indirect. If it is medial to inferior epigastric, it is direct.
So that is the differentiating point there. So that's the importance of this test. Now, yet another point. How will you do the Zeeman's test?
Sure.
What will be the position of the examiner?
Sir, patient will be standing and examiner will be sitting.
For the Zeeman's test, the exact method is the examiner should stand behind the examiner, behind the patient. And the right side, you have to use the right side of the examiner.
On doing the right side.
That is the exact method. That's the right method.
Side, examiner. Yes, sir.
So the examiner should stand behind the patient. And that is how you look for the 3 hernias.
Yes, sir.
Then yet another point. You mentioned about the Malgaine's bulges. What is its relevance in the examination of the case of hernia? Why is it that you have to look for it? Malgaine's bulges.
Sorry, sir, I didn't got the question.
Why do you want to look for the Malgaine's bulge?
Sir, that indicates poor tone of internal oblique muscles.
Right. So that is the reason why you should look for the Malgaine's bulge. How do you do that?
Sir, patient is kept in the supine position and I will be doing a head raising test. So while doing the test, we'll tell the patient to not to touch the bed with the hand, just to keep the hand over the body and to raise only the head. And we'll be looking for the bulge in the lower abdomen bilaterally.
Sir,
How
I
do you
have one
define the
question
Malgainis
here.
bulge?
Hello.
Please, sir.
Yes,
These are bilateral oval longitudinal swellings in the lower abdomen parallel to the inguinal ligament.
Right.
Sharad sir, please, you wanted to ask something.
Sir, I want to know what is the relevance of knowing the tonicity when gold standard is meshplasty?
Now, previously, when we were
There was hernia RFA, that was we had an option. Now the gold standard is plasty. Is it mandatory to look for a tonicity in clinical
now
examination?
there is not
It is not going to help us in the management.
No, but
Not
they
going
should know
to-
what is that Malgainis bulge, what is the weakness, how do you look for it? That is there. But of course, it's not necessary, sir. When we were studying, it was young man
was
with
there.
good musculature, Rafi. Young man with poor musculature, do plastic. But as a part of the routine textbooks, he's telling. So he should know what is Malgainis.
They should know, as a student, they
Yes,
should
yes,
know.
yes.
But
They should know.
it is losing its relevance. It may become obsolete
Okay.
after some time, I think.
correct, sir. So I want to share one point that the Hasselbalch triangle boundaries. Classical case is the rectus medially inferior epigastric inguinal ligament, but the new Bailey lower boundaries,
Lower
pubic
border.
bone. A pubic bone bracket, it is given as a iliotibial tract. That is, I want to opine that in the new Bailey 27th edition, the boundary lower, so candidate can present like the classical boundary, the new Bailey boundary is inferiorly the pubic bone. They mention like that.
Okay.
I want to opine the answer and the end about the latest Bailey.
It's usually, as you said, sir, the lower half of the rectus abdominis medially and the inferior epigastric. Now it is given as the changed.
Bone, the pubic bone, inferior bone. So I whether you are noticed or not.
Yes, sir, we noticed that.
Oh, okay. Good. Well, some candidate can present like that. That the inferior boundary is pubic bone or iliopubic tract. Change. That they are finally the boss or give the opinion.
Okay, sir. Okay, sir.
Okay.
Another
please,
obvious inspectory finding is missed. He has not commented on the shape of the swelling. It's important, no?
Sir, it's mentioned.
It's oval.
Sir, it's a ovoid swelling. I told. Actually, this presentation was made few days back. I had edited something, and this is not the one I was about to present today.
Like it is not there in the slide.
No, sir. This he sent it to me, but he has
few
changed
days
the
back,
website.
sir.
That is why I'm able to share it. Usually, I have a presentation, sir. Students will have some problem, so I share it. Okay, you can say. You said ovoid. Yes.
Sir, I mentioned it like, sir, it's a single ovoid swelling.
Okay.
Oh.
Where is the lower limit of the swelling here?
Sir, it is extending up to the root of scrotum, not extending into the scrotum.
Not into the scrotum.
What are the types of the indirect hernias, Abhijit?
Sir, it can be bubinocele, funicular. Sir, it's a hernia which is confined only to the inguinal region, not extending into the scrotum. Whereas the second one, there is a funicular type where the hernia is extending into the scrotum, but reaching up to the level of epidermis only. Whereas in the complete variety, it will be reaching up to the base of the scrotum. And the testis is
what about sliding hernia? What type?
Sir, sliding hernia is, sir, it's basically from the posterior wall of the sac.
It's included in direct or indirect?
Sir, it
forms part of the post, not entire posterior, part of the
posterior wall.
It forms the posterior wall of the
posterior, usually part of the posterior wall of the sac.
Yes, sir.
When do you say it's a giant hernia?
Sir, giant hernia means when the hernia is, when the base of the scrotum is extending beyond the midpoint of the thigh, which is classified into class 1, 2, and 3. In 1, it is reaching up to the midpoint of thigh. In class 2, the base of scrotum is reaching up to the knee. Whereas in 3, it is extending beyond the knee. It's also known as giant hernia or large hernia.
Abhijit, what will be the position of the testis in relation to the sac, especially in a case of a complete hernia?
Sir, testis will be lying posteriorly, sir.
Yes. Can you mention a condition where the sac and testis are closely related? May not essentially be in an adult. And what is its relevance?
You've given the entire answer. Not in adults.
So in pediatrics, in young children, this point is very important during dissection of the sac from the testis. So I think it's a practically important point. So do not relate it to your case. I think you should be aware of this practical point.
Okay, sir.
You see the sac in the testis inside the sac, it's like a congenital one. If you see it outside, it is acquired one. If the complete hernia, when it comes up to the root of the scrotum, the base of the scrotum, but the testis is palpated separately, not in the sac, it is an acquired one.
Sir.
So in a congenital one, if the patient leaves it for adult age, if you find the testis inside the sac, it's a congenital hernia. Okay, that is what Sir is telling you.
Yes, sir.
You are telling above and medial, the point that is good. What is that stressing about above and medial?
Sir, it indicates that it's an inguinal hernia and it is not a femoral one.
So if it is a femoral one, what will be that?
It will be usually inferior and lateral to pubic tubercle.
Below the inguinal ligament, you see a swelling, protuberant swelling, cough impulse. It looks like a femoral. Is it this femoral hernia common in males or females?
Sir, it's common in females.
In females, which hernia is common?
It's common.
Sir, it's inguinal hernia.
Right, very good.
Indirect inguinal hernia.
Right. When Professor Gobi sir asked you the question, why do you say the swelling is a hernia? You need not beat around the bush. You can say two things. You see
sir, reducibility and
the two cardinal signs of an uncomplicated hernia. It is given in italics in italics in thus cough impulse and reducibility.
Yes, sir.
Okay. Right.
Sir.
So Professor asked what was cough impulse. Cough impulse, you can define it as like this. Momentary appearance of a swelling in a normal plane is called cough impulse, or increase in size of a pre-existing swelling is again called a cough impulse. Okay?
Sir.
Right.
Vijay, what are the conditions to get the cough impulse? What are
so it can be seen in inguinal hernia, laryngocele, meningocele, then empyema nascens.
Any swelling which has got a communication with the
body cavities.
Body cavities.
In the groin, any other swelling in the groin?
Sir, saphenopharynx.
How will you differentiate this saphenopharynx and this hernia?
Saphenopharynx usually can be associated with varicosities of lower limb.
Varicose vein, okay.
And fluid thrill can be elicited.
Very good.
So that Kurvi-Haynes sign may be.
What is that sign?
So the presence of cough impulse with fluid thrill in a saphenopharynx.
Okay, correct. Okay, fine.
You got Crowell sign.
Yes, sir.
Okay. Scrotal examination is normal. Testis is normal, you said.
Yes, sir.
Right. Penis circumcised, meatus normal. Did
Central
you look
position.
for central in position? Right. Urethra normal.
And
no stricture. Where do you look for the urethra, bulbar urethra, if you're asked to examine?
Sir, patient will be usually kept in the left lateral position or in the knee elbow position, and it will be checked in between behind the scrotum.
You lift the scrotum and palpate, that is enough. Don't put the patient in left lateral, right lateral, or in the prone position. The patient is lying down, you just lift the scrotum and palpate. Don't disturb the patient.
Palpate pinoscrotal angle.
Pinoscrotal angle. Okay.
Yes, sir. Yes, sir.
Pinhole meatus circumcision. Scrotum is normal. Suppose the scrotum is not developed, what do you think?
So it's maybe a case of undescended testis.
The scrotum developed absent testis, what do you think?
Scrotum
is well developed absent testis.
Sir, it's retractile testis.
Retractile testis. Right, that is one. Your exam. Now you have done a DRE. Inguinal swelling is resonant on percussion. That's you said it reduces with a gurgling sound.
No vowel sounds are over this.
Yes. Is it easily reducible?
Sir, it was difficult to reduce the initial part, but the later part it was easily
No,
reduced.
you say it is an indirect, direct hernia. In direct hernia, will you have the typical one where it
No.
reduces, or it
So
is?
for this case, it was not complicated. It was easily reducible.
Suppose it was an indirect hernia. What are the
Sir,
things you look for in reduction?
If it is an endothelial, the initial part of reduction may be difficult, but later part will be easy. But in a omendothelial, the initial part will be easy, but the later part will be difficult to reduce.
Yes.
So there are no vowel sounds, but all the features are suggestive of.
Yes, sir, but I didn't got a vowel sound over the swelling, sir.
How long will you auscultate to before you declare there are no vowel sounds?
Sir, minimum 3 minutes, sir. So minimum 3 minutes.
So at the end of 3 minutes, you didn't hear vowel sounds, huh?
No, maybe because the content may be so large. Content may not be so large.
But you are doing gurgling and all.
That was there, but sir, I didn't got the vowel sound.
Okay. Yeah, yes, and yeah, DRI, digital examination was done.
Yes, sir.
Sphincter growth and no prostatomegaly. Right, by doing a DRE, can you say whether the prostate is malignant or benign?
Yes, sir.
What are the
Usually
points?
in malignant one, prostate will be hard in consistency and it may be fixed to the mucosa or surrounding structures. But in benign one, it will be usually firm in consistency.
Will there be any obliteration of?
Yes, sir. The median raphe will be obliterated.
Raphe or groove?
Groove. I mean groove.
So one is hard, irregular, and you cannot run the prostatic mucosa, and the obliteration of the groove will suggest it is malignancy.
Malignant one, sir.
Right. Your digital examination does not prove there's no prostate. But how will you look for whether the patient has got prostatomegaly without any symptom?
On digital examination,
digital examination is normal. Is there any other way of looking for?
Ultrasonography, sir.
Right. Ultrasonography is not working on that day.
I don't know, sir.
What is residual urine?
Okay. In the USG post-voidal residual urine amount will be calculated.
Is not working.
Okay.
How will you look for the residual urine? What is the normal residual urine? When do you say the residual urine is important to declare it as a prostatomegaly?
Sir, when it is more than 125 ml.
More than 100 ml. 30 to 50 is normal. How will you look for it? The residual urine?
I don't know, sir.
After voiding, you put in a catheter and empty the bladder and look for the residual urine. Simple thing.
Okay.
You're all familiar only with the ultrasound. Right. Okay. No other systems are just clinically normal, isn't it? Sir, can we go for the?
Yes, sir.
Your summary doesn't need. Sir, please comment on this, Satish. Sir. I don't think your summary should be such a big. You can see a 50-year-old man with occupation with bilateral swelling in the groin with cough impulse and reducibility. You need not mention that he was you can say he's a smoker, not ex-smoker, ex-alcoholic.
Okay, sir.
You brought all the history into. You can just say 54-year-old businessman what is his occupation with bilateral groin swelling occurring at the same time with cough impulse and reducibility with the testis and scrotum normal, penis normal, DRE is normal. That is enough. You again come to the local examination. This is not a summary. Summary should be within 4 lines, 5 lines. When you write in your exam, your case sheet should be okay.
Okay, sir. Sir,
any comments, Satish or Sarath?
No.
Agree. I completely agree with you, sir. That's not really a summary.
This is not a summary. You are again repeated 2 of your slides.
Repeated all the
almost
on examination, local exam, everything. Yes. Depicted.
And kindly do a PPT presentation rather than a PDF. You can convert the PDF into PPT.
Sir, sir,
You could have-
this
you could
sir,
have
mine
sent
is
that way.
PPT, but
could have said-
when I
you could
send
have-
it, oh, okay, sorry, sir.
No problem. No,
No,
result to be corrected.
I will
Okay.
go for the management.
Yeah.
Abhijit,
Yes, sir. Please,
I
sir.
have
Sir.
one suggestion.
Please, sir.
Sir.
The diagnosis, once you mention it is bilateral incomplete reducible direct inguinal hernia, bigger on the right side. There's no need to say that no complication, without complication. I think.
Yeah, when you say
it's
the
self-explanatory.
reducibility, when you say
Okay, sir.
cough impulse and reducibility, you don't need not say any complication doesn't come.
Yes.
Okay, okay, sir.
Just a suggestion.
I think it's given in the books. That's what they are following it.
Not necessary. Once it is reducible and
There is no complication. Yeah.
there's no complication. And a complicated case will not be kept for your exams. Okay.
Okay, sir. We'll go for a management.
Yes, sir. Please, sir. Yes, Abhijit, we can stop
Let's
sharing.
start.
Sir,
Yeah.
Yes. How will you manage? You can start.
sir,
Abhijit.
sir, 1 second, sir. I'm just switch on in the video.
Yes, Vasu,
Sir, am I
Ayyappan,
visible
you are
now, sir?
correct. Somebody has said it's cruel. Somebody has put a question to me, to all the panelists. Vasu Ayyappan. Catheterized residual alone is very crude. It is not crude. Don't use that word crude. I just asked that question. If suppose ultrasound is not available, that is what. You cannot use the word crude. Who's that Vasu? I just asked as if whether he knows if an ultrasound is not available, how will you measure? I didn't say that. Please don't use the word very crude. But measuring the residual urine by putting in a catheter, is it crude? That means putting in a catheter for every surgery is crude. Are you a doctor or are you a... you cannot... crude, I just... So, sir, I asked that...
surgery.
Sir, please, sorry, I didn't ask that. Sir, it is crude. I didn't ask whether... I said, whether does he know the answer? That is what. Testing the knowledge, that's all. Ultrasound is now available everywhere. Yes. I want to know whether... Yes, come on, you go with the management. Abhijit, is...
Such a
Would
question.
you like to do any...
Such a questions and... Yes, sir. We are encouraging such questions. No problem. Okay.
Please, sir, I'm not finding fun. Yes, Abhijit. Yes, now one. Would you like to confirm your diagnosis or is it a clinical diagnosis? Hernia.
Clinical diagnosis.
It's a clinical diagnosis. Then
Yes,
why do you
we are
want to do the why you want to do the investigations?
Sir, I want to. Hernia is basically clinical diagnosis.
Yeah, it's a clinical
And,
diagnosis. What
my
are the
task
investigations you
That will
want
be to correct this by surgery. So, investigation, hemoglobin.
I think you can remove the mic, but you can speak over the computer audio.
The patient is diabetic. I want to know the blood
you
sugar level, HbA. Sir, now am I audible, sir, correctly?
Yeah, why do you want to investigate the
I
patient?
will do a routine investigation including hemoglobin and red count.
For anesthetic purposes.
I want to see whether any underlying other cause for presbyterian this hernia and to know whether the patient.
Okay. Right, everything has come normal. The patient is fit. The chest X-ray is normal. The ECG is normal. His anemia is his blood count, hemoglobin level is good.
Sir, I want to see whether anything in this hernia.
Pardon?
You are not audible, Abhijit.
What is it you want to do?
Sir.
See, every investigation is normal. The anesthetist has given fitness. My question is, Abhijit, would you like to operate on this patient? Why do you advise surgery? The patient is asking you, why do you want a surgery? I don't have any pain. I just have a swelling. Why do you want to operate on this patient?
Usually, although the direct hernia will not go for complications easily, but still he is complaining of dull aching pain with bilateral symptoms. I will give him an option of surgery considering
No, you
the
can tell
discussion
him what all
regarding the
the.
conservative management also.
Okay. Right. What is the surgery you want to do?
Sir, I will give him the option of both open surgery and laparoscopic surgery. But since in this case it's a bilateral hernia, I'll be preferring laparoscopic hernia repair if the patient is fit for surgery from anesthesia side.
Yes, sir. Please take out, sir. Sir. I am being.
So he's having symptomatic since 6 months. He's having pain. I think he needs intervention. So what laparoscopic surgery you would like to offer him? Bilateral.
Bilateral totally extraperitoneal repair or tap, both can be given according to the expertise of the.
Which is ideal?
Maybe tap is more associated with complications like bone injury, bladder injury, and it is useful. That can be by young surgeons, but TAP will be needing. It requires more learning curve. So, and injuries to bowel and bladders are unlikely with the TAP. So I'll be preferring.
Let me ask you, which is technically easier? Suppose you are given the option of TAP and
Pardon,
TAP.
sir?
Which is more easier,
Sir?
TAP or TAP?
Sir, TAP.
TAP is obviously easier. But what is the problem of TAP compared to TAP?
Sir, here we are incising the peritoneum and also so there is increased chance for bowel and bladder.
Other than that, any other risk when you go TAP? Suppose you are dissecting two lateral.
Mesh.
One is mesh placement, and yet again the bleeding complications are
Yes,
more.
sir.
So, which
yes,
are the
sir.
bleeding sites? What they usually go with certain names.
Sir, then venous plexus of Benjamin. One thing, then bleeding from the corona mortis artery. External iliac vessels.
Is it corona mortis artery or
vessels.
What is that artery called?
Circle of death or
corona mortis.
Aberrant obturator. Sir, it's an aberrant obturator artery.
Yeah.
Aberrant.
Right.
Obturator. Yeah.
Yeah.
Where do you keep the mesh? Being a bilateral hernia, where exactly do you keep the mesh? And what is the precaution you should take? What do you call that line, orifice?
Sir, myopectineal orifice of Frochard.
Who is Frochard?
Sir, Henry Frochard is a French surgeon.
French surgeon. What is the advantage of keeping the mesh in that area?
Sir, this area is the one which is containing inguinal, femoral, and obturator hernia. So if we intervene this area, we'll be also preventing development of other things also like obturator and femoral.
So that is the greatest advantage of a lap hernia repair. That is, you are seeing as if it's a bird's eye view. From above, you find all the orifices. And which is the one that we usually miss in an open hernia repair. The hernia which we that usually miss or overlook.
Sir, obturator hernia.
That is one. Femoral hernia is very difficult. Femoral hernia, because the descent or the description of a femoral hernia is it goes down, then it's just like a retort. So it comes back. So it's very difficult to identify it in an open hernia repair. So quite often you find that the patient presents later with a femoral hernia. So that is one reason why the protagonists of lap hernia advise lap hernia or open repair. So that is one reason. What are the disadvantages of a lap hernia repair?
Sir, the procedure need general anesthesia.
Yeah.
And learning curve for doing laparoscopic hernia repair is quite high.
What about the complications, which is the one complication that puts the patient in great disability after surgery? Seroma formation, especially in a huge hernia. When you leave the distal sac into the scrotum, you find that they present with seroma, and it's very difficult to convince them. That's one thing.
Okay, sir.
Any other reason?
Sir?
Any other reason? Any other disadvantage of lap hernia?
While we are applying clip or staples, if it is applying over the nerve, patient can
that is one problem. In spite of having dissected everything,
yes, sir.
Is it a must that you should always apply clip or a
No,
staple? No, so it's not. So what principle keeps the mesh in place?
Sir, it is in such a way that it should cover the myopectoral orifice.
So what is the size of the mesh that you would like to prefer in lap hernia repair? Size of the mesh. Very important, no?
It is in such a way that, sir, it is in such a way that it is covering or it should be 6 centimeter lateral to the pubic tubercle, and laterally it is extending up to anterior superior iliac spine, and 5 centimeter above the defect, and below it should be at the level of deflection of the vas deferens.
Right.
10 by 12 centimeter.
Suppose you are doing an open hernia and you want to keep the mesh. Which are the placement methods? Otherwise, what are the types of mesh repair? What I mean is
onlay repair, inlay repair, sublay repair.
Pardon?
Inguinal.
So it is the one that we usually do. Open repair.
You're doing is only repair, sir.
Is there a little older method where you can deal both the hernia through the same incision? What do you call it? Both the incisions through a. It is again also named after a surgeon.
Only inlay and
Pardon?
Sir?
You can approach both the hernia through the same incision.
Bilateral, yeah.
Bilateral.
Mm.
What do you call that technique?
Srinivasan sir is giving clue.
Policeman says stop.
Stop pass.
Stop pass technique. That was actually the one of the reasons. Actually, something like a lap hernia prior to the lap hernia came.
Yeah.
That was more commonly used. So, what is the disadvantage of a stop pass technique?
Yes, sir.
It's a huge incision, no? A wide incision is there.
A long incision like a full incision or a subumbilical midline incision, and we need a large mesh which is extending 2 centimeters subumbilical midline and the tubular spine. So, posterior
can also use fan and steel incision.
Yes, sir.
What are the types of mesh you can use? The types of mesh that is available and which is better? Types of mesh.
Low weight mesh, low weight, medium sized, and heavy weight. Macro mesh, macroporous mesh.
What is the criteria to say whether it is low weight or a high weight? On what basis? It's given in Bailey.
It is plus grams per meter.
40 grams per square meter. Less than that, it is low weight. Which one would you prefer?
80 is considered as heavy weight.
Which one would you prefer? The one with large pore size, small fibrils, or the one with thicker mesh? Which would you
one
prefer?
With one
non-absorbable, the non-absorbable with wide pore, because that helps in the ingrowth of the fibrous. So that is the one that is preferred. How will you classify the mesh, the types of mesh?
So it can be biologic synthetic mesh or a composite mesh.
It's not clear. Clear Allah.
Abhijit, not clear, not
Sir.
clear. Oh, next is.
Now it.
Jonah.
Hmm?
Sir, am I audible
How
now?
will you divide?
Yeah. How do you
Now it's
classify?
possible. Okay, proceed.
I mean, let's have a meeting session.
Abhijit, the question was what are types of...
മൂന്ന് ക്ലാസ്സേ ഉള്ളൂ, 3 ടൈപ്സ് ഓഫ് മെഷേ ഉള്ളൂ. ഏതൊക്കെയാ അത്?
Biology, composite mesh.
Yeah. Which are the 3
Abhijit,
types of mesh?
Abhijit, what is biological mesh? What is biological mesh? Not audible.
Human. Am I audible?
No, you are. It's
not clear.
Interrupting. I think you can remove your headphones for. Then it is coming good. Yes, Abhijit.
Yes. Abhijit?
Sir, am I audible now, sir?
Yeah.
I ask one question. What is biological mesh?
Sir,
what do you mean by biological mesh?
Sir, am I audible now?
Not audible.
Sir, these are from human or bovine thing like not as porcine intestinal submucosa or a bovine pericardium or from human alone.
Your answer is not clear. Sorry, your answer is not clear. I can't see anything. See or hear.
Am I audible now, sir?
Biology mesh is sterilized non-immunological cellular connective tissue. That is biology mesh.
Yes, sir. Non-inflammatory, non-immunogenic.
Okay, fine.
Sure.
Sadish, you can continue.
So, which was the gold standard of hernia repair? Which was?
Shoulders repair.
No, presently it is the Schulde. In the open method, it is the Lichtenstein's tension-free repair. But why did the Bassini's repair, which took 100 years or more, why did it fall in disfavor?
So it was associated with excessive tension. So postoperative pain and complication was more.
What complication?
Postoperative pain was more.
What other? Recurrence was very high.
Recurrence was
the recurrence
very
rate? Recurrence rate. At one point of time it was 15%, then it came down to 5%.
5%.
They considered that even that 5% too high. So that is why other methods came in.
Yes.
Yet another point is, it is not a physiological repair. See, you are approximating a ligament to a tendon. So that is yet another reason why it is under tension. So that is yet another reason why it fell in disfavor. Now, in your beginning, you said that the anesthesiologist has given the anesthesia and surgery. See, there is no hard and fast rule that it should always be done. I agree for lap, it is anesthesia is required. But even under local anesthesia, you can do it.
Yes.
What are the advantages of doing a hernia repair under local anesthesia?
Sir, on-table cough test can be done to see for any occult hernia. And also, pain will be also less.
Early ambulation.
Early ambulation. Postoperative urinary retention chance is also yes. Early ambulation can be done. Daycare surgery can be given.
Yeah, daycare. What is the local anesthesia? Where do you infiltrate?
Sir, it's lignocaine with or without adrenaline. And
which nerve do you
sir,
block?
2 centimeter above and superior to anterior superior iliac spine. It's 1 point of infiltration. Then pubic tubercle area.
You can do it under the anesthetist can do it under the ultrasound guided nerve block.
Yes, sir.
Yes, sir. Gopi, sir. Anything else?
Yeah, we should also ask about the classification.
Yeah, what are the various classifications? What is the present EHS?
Classification.
Sir, EHS or European Hernia Society classification, based on which hernia will be classified as into a table where P is the primary and R is the recurrent one. Then depending upon the size of the defect, it is divided into 0, 1, 2, 3, and X, of which 0 is there is no defect, and 1 means the defect is less than 1.5 centimeter, where only a tip of the finger can be insulated to the deep ring. 2 means defect is between 1.5 to 3 centimeter, and where 2 finger can be insulated. And in 3, it is more than 3 centimeter, where 3 finger can be insulated. X is not evaluated for the deep ring size. And again, L, M, and F, that is the lateral, medial, and the femoral hernia.
Okay. What is the modification, Gilbert's modification?
Sir, in the Gilbert modification, there are 7 types. In the type 1, it is the tight internal ring, whereas in type 2, it is a moderately enlarged internal ring. And in type 3, it is a patulous internal ring, which is more in size with a sliding component or a total component. Type 4, here it is type 4 and 5 are direct hernia, and in type 4, it is the entire posterior wall is defective. In type 5, only the diverticular defective will be there. In type 6, it is a combination of both direct and indirect inguinal hernia, and in type 7, it is a femoral hernia.
If a hernia present with the hydrocele, what is the hernia present?
Sir, it's known as Gibbons hernia, sir.
What is?
Gibbons hernia.
Oh, correct. Okay. Saratan, sir. What else? Hello?
Hello, sir.
Hello.
Can you name some none other named hernias?
Sir, the Meckel's diverticule is the content, it is the Little's hernia, and the appendix is the content, is Amiant hernia. Narath hernia means the presence of congenital dislocation of hip along with a femoral hernia. Gibbons hernia is the one which is having hydrocele with hernia. And Riches hernia, where there is a part of antemesenteric border of the bowel is the content, which is going for strangulation.
What is sports hernia?
Sportsman's hernia.
Sir, it's basically seen in orthopedic injuries, when especially like when there is an excessive muscle tear, or especially adductor muscle tear, patient can present with inguinal pain. And on evaluation, usually clinic herniation won't be there, and the imaging investigation of choice is the MRI. And hernia surgery is only the last resort for all other failure treatment. So it's basically an orthopedic traumatic injury.
What is the precaution? Please, sir, please.
Sports
it's usually
seen in rugby and
yes, sir, rugby players.
What is the important precaution you take in the giant hernia?
Sir, excessive manipulation of the scrotum and cord should not be done.
Can you giant hernia under laparoscopy?
Sir, we have to reinserting entire content into the abdomen can precipitate compartment syndrome. So it's not an ideal thing to rapidly do that.
Actually, enter giant hernia, so it will not be ideal. It will not do contraindicate giant hernia. And how will you manage giant hernia? How will you manage?
Sir,
content is scrotum. How are you going to manage? Hold the man.
Sir, open surgery with component separation technique or relaxation of the abdomen with botulinum toxin injection can be considered.
Before the surgery, how will you prepare the patient?
Sir, we have to optimize the systemic things, especially the respiratory system. We have to start him on insulin spirometry, and we have to make sure that patient is well ambulatory and the chest status is very fit. And
keep the patient at least 2 weeks foot and elevation.
Foot and position.
So that go into the abdominal cavity.
Yes,
suddenly pushed into the abdominal cavity, patient has dyspnea and other problems, respiratory errors. So prepare 2 weeks foot and elevation. It may go inside, so little part. the giant hernia. And
Sir.
what is the special concern you will take in giant hernia on old people? Hernia repair.
Orchidectomy consent.
What is that? These things. Hamilton Bailey.
Sir, there are Coons operation and Hamilton Bailey operation. In
What is
Hamilton
Coons?
Bailey operation, the cord structure, the cord will be divided from the inguinal canal, and the cord will be removed, and both the proximal and distal end of the cord will be sutured, but the testis will be kept intact into the scrotum itself. Whereas in Coons surgery, we will be also considering the orchidectomy along with the removal of cord structures.
Coons, you are doing a funiculectomy. You remove the cord structures.
Yes, sir.
Hamilton Bailey removes the cord structure plus the testis. So special
Yes, sir.
consent.
Sir?
All people hernia repair.
What is loss of domain?
Sir, in case of a long-standing hernia, which is very large hernia with a large quantity of bowel in the sac, due to long-standing process, the muscle will go for contraction and the intra-abdominal space will be low enough so that when we are reinserting the entire sac and back into the abdomen, it will cause this problem. So the previously occupying site is now lost.
When do you say there is loss of domain with reference to in the percentage you have to
When there is
mention
more than 40% reduction, I think.
When you keep a mesh,
Sir.
these are the points that you'll take note of, especially in terms of recurrence.
Medially, the first key bite should be taken over the fascia covering the periosteum of the pubic tubercle, and the medially the mesh should be covering a minimum 2 centimeter medial to the pubic tubercle over the rectus, and inferiorly it should be fixed to the lower lip of the inguinal ligament, and superiorly to the conjoint tendon with a fishtailing of for the internal ring and cord structure.
Laterally, extend and why?
Minimum 5 centimeters, sir.
It should cover adequately so that the recurrence from the internal ring and the medial end does not happen. That's it.
Yes.
What are the complications of hernia, inguinal hernia?
Sir, it can lead to hemorrhage, hematoma, seroma formation, wound infection.
I'm talking about hernia.
Vijit, you answered he said it is not complications of inguinal hernia, not inguinal hernia surgery.
Surgery.
Oh, sir, complications, irreducibility, obstruction, strangulation, incarceration, and inflammation.
How do you manage a case of strangulated complete inguinal hernia?
Sir, after taking the consent for resection anastomosis, I'll be taking the patient for surgery. And initially, we'll putting an inguinoscrotal skin incision, and we'll be looking for the characteristics of the content. And while dividing the sac, we should take care not to spill the toxic fluid into the surgical field, so that mop can be kept. Sir, mop can be kept all around. Catheterize the patient preoperatively. Intraoperatively, we have to keep mop all around so that the toxic fluid.
No, that is in doubtful. That is in doubtful cases, Abhijit. Basar is asking in strangulated. Strangulated, do you think you can put a mop and give 100% oxygen?
Strangulated, we should take care that the bowel should not go back into the abdomen.
So what is that precaution? How do you manage it? You have taken an inguinoscrotal incision. Okay. Then
we should start
dissecting from the scrotum. Then
when do you open the sac in an uncomplicated hernia? When do you open the sac in an irreducible hernia?
Only the fundus should be open, sir. The neck should not be open at the time.
Open the sac first in an irreducible hernia, whereas in an uncomplicated hernia, you dissect up to the ring and then open.
Okay. Yes, sir.
A patient comes to you with an irreducible hernia in the midnight. Will you reduce it manually or elevate the foot end, put him on some diazepams and reduce it? Is it advisable? What will happen?
Practice.
What is
If there is no
if there is sight irreducibility, no signs of obstruction, no signs of strangulation,
yes,
will you reduce the irreducible hernia or you take him off for surgery? If you reduce it, what is the complication you get it? You try to push it
if there is a missed strangulated segment,
it is called a
that can
reduction.
lead to bowel injury.
Reduction en masse. Have you heard the word?
Reduction in mass. Yes, sir.
So never do an irreducible hernia. Forcefully reduce it by lifting the foot end and giving some relaxants. Okay.
Yes, sir.
Yes,
we can go for another 2 to 3 hours if it keeps on going.
I think it's time for conclusion.
Yes, sir. Please, sir.
Anything you want to ask?
Pardon?
Satish?
ഒന്നുമില്ല സാറേ, മിക്കവാറും എല്ലാം ആയില്ലേ?
I will show a rare things as related to hernia. Candidate should identify. So, hello, sir.
Yes, sir. Please.
I will show one historical thing. Whether candidate can show me.
Abhijit, your presentation.
Abhijit, identify that thing.
Thank you, sir. Sir, it's not visible in the screen, sir.
Not visible, sir.
Not visible. No, sir. Is visible?
No, sir. No, sir.
No, sir.
Yes. Abhijit, can you identify this?
Sir, it's a truss. Sir, truss.
It's a made of leather. It's a old people. If you're inoperable, you can keep. And this is with the leather,
yes,
and this is with the metal.
Yes, sir.
The sac and the hernia protrusion can be uploaded.
Yes, sir.
It is I don't know. It is found in the cupboard, department cupboard.
Nice thing. Don't use it.
Not using.
Abhijit,
keep it in museum.
Abhijit, my closing comments about it is you should be a bit bold, and when you're presenting in a forum, you should be well versed with your net connection. Practice it, come back, put it in, present it very clearly, and if you should
actually,
not.
It was tried previously,
no
but
problem.
I don't know why it happened.
No. I will tell you. You correct it.
Sorry, sir.
And don't beat around the bush. Be straightforward. You can very well say answer no in this forum, no problem. But in the exam, you come prepared much more well. Some more. We have a lot to discuss. We are not discussed about the anatomy. What are the normal factors? If it's keep on going, it will go for up to 1 o'clock. But Professor Rajan and Babu sir are there. Gobi sir, we have to conclude. So they will go for the closing comments. Abhijit, you have done a good job. Come back with a good in net connection next time. Thank you.
Thank you, sir and Srinivas sir and Prabhu. And before I want to express my sincere gratitude towards the dancer and the Andhra sir. As well as this program started with this is actually a brainchild of Abdul Latif, HOD Surgeon Trivandrum, and Dr. Salim, Mohammad Salim, HOD Assisia Medical. They asked me to conduct this study at this program. So with their all support, we started. And I also expressing my sincere gratitude to the students of Kerala, all the PG students and all the staff of the other medical colleges and externals participated in this program, and as well as the RPFs from Trivandrum and Santosh John for advice regarding the next, and yours an expert in as the conduct RRC. So expressing my sincere gratitude towards all the people, all the HODs of different medical college of Kerala and external outside Kerala, and also once more sincere thanks to Rain sir and the Babu sir. And before going to Dansara and Dayananda Bhasan. I am inviting Dr. Mohammed Salim in few words. Sir is the HOD of surgery.
Yes, sir. Good evening, sir.
Good evening, sir. Am I audible, sir?
Yes, very much, sir. Very much. You are traveling.
Sir, because I'm still traveling. Sorry, please excuse me. But then I have written my opinion definitely in detail in the SI group as well as in the KSPGS group. It is my sincere wish to congratulate everybody concerned with this effort suggested by I was only instrumental in suggesting with Abdul Latif to start this program. So it happened to be very enjoyable because it is given to one of the dynamic person ASI chairman, Dr. E.V. Gobi sir. So who has taken a lot of pain, and he was inevitably every week conducting it in a meticulous way, so that it was all a feast of academic bonanza, as I wrote there. And I wish also to have our evaluators, Professor Dayananda Babu sir, and the outset, Professor Dayananda Babu sir and Dr. Professor P. Rajan sir, for having spent that much lengthy sessions, patiently listening to all the presenters, all the examiners to get their myths corrected as well as their opinions having a consensus, and finally summing it up with a gem of pearl of opinions in the form of actually 10 commandments from Babu sir, and also the wisdom shed by the mature opinion always given and enlightening all the viewers. And every week I was feeling to rush to the screen at about 8 p.m. at least to listen to. And most of our colleagues are also saying, including Professor Vasu, who is another professor of our department, our college. So I wish, it is my humble plea to all the organizers, all the listeners, all the presenters, as well as the examiners, and our learned professors, duo professors who are evaluators, to not to drop this program abruptly, but it is my sincere plea and wish to have it continued as an indefinite program, at least once a month or at least fortnightly. That is the only humble suggestion which I want to raise, along with the felicitation of all those who are instrumental in this program. So let me plead once again to the listeners as well as to the organizers and the distinguished dignitaries on the dais for evaluating this, to have their valuable time, precious time spared to continue this very vital program, crucial for training not only the PGs, but all of us like me who are continuing as examiners in PG as well as UG, to get a vital conclusion and guideline through the learned professors. So let me raise it to the forum to agree with my suggestion, if possible, if from the by giving a valuable suggestion from Dr. Professor Gobi sir's side, as well as from my learned evaluator duo professors. Thank you all so much.
Thank you, sir. We go to the answer.
Good evening, everybody. First and foremost, let me introduce to Gobi and his team for a wonderful session, multiple sessions that we had. Just like Muhammad Salim was telling, we are ready on Saturday or Sunday, no matter which day, 8 o'clock, I myself make free to enjoy this session. It is a wonderful experience. Now, as far as external examiners, Subramanian sir, Sharat Chandra and Satish sir, Alex missed it out. I don't know why. He's from Calicut. You did a wonderful job. And Abhijit, yes, as Subramanian sir said, you must have a little bit of certainty in presentation, no matter what. Because hernia is a very simple case, it's a very common case kept. And one can expect, as Professor Subramaniam said, you can go on. You will not anywhere. Now, as far as a candidate is concerned, they should look into the instigating factor for a hernia, other than congenital hernia. The instigating factor is anything which increases the intra-abdominal pressure, about which the examiners have already told about. The second thing is the candidate should have a good idea of the pathological anatomy of hernia. And third thing is the pathological aspects of clinical symptomatology. If he says pain, he should evaluate why there is pain, not just say that it is just traction on the mesentery. With a little bit of omentum or a preperitoneal fat that is herniating, you can't expect the omentum, the root of the mesentery to be dragged to cause. A larger hernia, yes, but a smaller one, no. Whereas an indirect hernia, yes, is more symptomatic than a direct hernia. I will quote Professor C.K.P. Menon using saying an analogy. A direct hernia, he used to say, is like a shy girl. It just comes out and feeling shy, it gets in very quickly. Whereas an indirect hernia is a much more elaborate, which he says is like a prostitute. It's very difficult. It comes out, stays there, unless you try to push it back and takes it inside. So that is an analogy which Professor C.K.P. Menon used to say about the direct and indirect hernia, historical, because his hernia is full of history, starting from talking about the Bassanese repair and whatnot. Hundreds and hundreds of methods of repair had been done to achieve what we are standing now. No matter whether you do laparoscopic or open method, there is a principle, underlying principle in treating hernia. Number one, you have to optimize and correct the provocating factors. Number two, dealing with the hernia, you deal with the contents, you deal with the sac, and you deal with the defect. Today we have got innumerable materials, the synthetic material, the semi-absorbable material, totally absorbable materials, everything to close the defect. Because a good Samaritan thing should be doing the job and not present there once the purpose is served. Now, regarding the Siemens test and the finger invagination test, I think finger invagination test is quite a very painful thing, and it's probably taken out of the clinical methodology. Whereas the Siemens test, the 3 fingers kept. I don't know, they keep on saying, because the brain has got only a 2-point discrimination methodology. We can't discriminate 3 points at a single time. Professor Chintamani always is against a Siemens test. I'm also against a Siemens test. Anyway, it is debatable. Now, the European hernia system classification is a very simple system compared to the Gilbert and the Nyhus classification. No matter what, they all talk about the defect. They talk about the recurrence. They talk about the femoral hernia. And people keep talking about the laparoscopic repair and correcting the obturator. But to my knowledge and to my experience, I haven't seen many people going down to the obturator foramen. Yes, the femoral and the inguinal canal, yes, it's good. Somebody was talking about the Rennie Stoppa's hernia repair. The Phanenkstein incision exposing the whole thing as for a retropubic prostatectomy and putting a very large mesh. Yes, it is. It was quite a painful procedure. The best open method, I would say, is the Shoulder's repair. Very many methods are there. And people have arranged or talked about lateral approach, properitoneal mesh placement, etc., etc. Well, I would stop here. I would stop with the history that the candidate should know. Hamilton Bailey lost his index finger. Very astute clinician, a lady presented with distended abdomen and a femoral hernia. And an astute physician as he is, he thought it is a femoral hernia that is responsible. And while trying to divide the lacunar ligament, he injured his finger, developed a streptococcal tenosynovitis. At that point of time, when there were no penicillin, he had to lose his finger. Incidentally, it was a case of primary peritonitis for the old lady. That is history. I was telling, hernia is shrouded with historical aspects. Well, as a student, you will not find time to read the history, but it's very interesting to go through the history of hernia surgery. It's a long, long, long story of hernia. The saga of hernia has come to such an extent that we are now talking about in larger hernias, extended TEP, the component separation, etc. And in incision early, I will talk about larger hernial sac, the Tanaka's rule, and so on and so forth. I will leave the rest of the talk to Dr. Dayanta Babu. Thank you very much for inducting me into this particular situation, and I enjoyed it every bit. Thank you, Gopi. Thank you, participants. Thank you all the external examiners.
Also,
I think I have to congratulate Professor Gopi for starting this venture, and the entire period was enjoyable period. I was ready at 8 p.m. I think over so many weeks for the last few months, and if somebody can organize it, it will be well and good. I think one or two sentences about before going to my 10 points, 1 or 2 minutes for my surgical handicraft. There was a book called Pice Surgical Handicraft, which was very popular, but somehow last so many years, they were not revising the chapters. Especially so many things changed, especially even cannulas, color coding key. So many things changed and they were not revising. So the JP, which the chairman, he asked me to write a book. So that is the genesis of surgical handicraft, which he told me on 2014, and there was a target kept for me, which was in 2015 December. Somehow I finished, but I could not complete the entire book. So now it was sold out, and in 2019 it was not available. Again, the Pice has come out with reprint of the old 1990 book. So meanwhile, I was doing the revision. The COVID time, it was, you know, that it's a difficult time for all of us, and I got a free time. So I have completely revised, and I have added 13 more chapters. I have added another 150 pages. And now I feel that it is a pakka surgical handicraft. And I have added the new topics like muscular anastomosis, intestinal anastomosis, feeding jejunostomy, surgical nutrition. It's a very, very important topic. Then general topics like consent, negligence, breaking the bad news. So many chapters were added. So I feel that it has come out nicely. It is available in Amazon. It will take another 2 weeks for it to come to the bookshops. Right now it is available in Amazon. Now coming back to the hernia, the history is very important in hernia. Recently, I heard a story from the physician that a patient was having epigastric pain and he used to faint in between. He was a shopkeeper in a medical shop. And he went to many, many doctors, surgeons, physicians. It was not died. It was only a case of hernia. It will produce a dragging pain in the epigastrium. When it is because of the pain by the descending, the omentum, the mesentery. So when there is traction on the mesentery, there will be pain in the epigastrium. Nobody examined this genitalia. Nobody has found the hernia. And finally, this diagnosis was made by a physician, one of our medicine professors. So history is very, very important. Of course, the history of cough, constipation, and BOO, all are important. Now, the terminology prostatism is obsolete now. So the Continent Society has come out with definitions for the so-called lower urinary tract symptoms, LUTs. The LUTs may be divided into 3 types: storage LUTs, the void LUTs, and the post-void LUTs. And definitions are there in Bailey. I request all the PGs to read all the definitions rather than telling frequency. Everything is defined, so that they should go through. Second is always examine the patient in standing position while the examiner sits. This is the ideal position. The examiner will sit and the patient will be standing. Always examine both sides and always examine all the hernial sites. Sometimes there may be hidden hernias. So always examine all hernial sites. Examination of genitalia is not only for the urethral structure. Sometimes there will be dual pathology. Sometimes maybe ureterostomy, hypospadias, perineal ureterostomy. That is why the Norman Browse says examination of genitalia is not complete if you don't examine the undersurface of the penis. If you don't retract the prepuce and examine. If you don't examine the undersurface of the scrotum. Three things: retract the prepuce, examine the undersurface of the penis, examine the undersurface of the scrotum. If hernia is reducible, always the student will get confused. There is no need to differentiate direct from indirect. So that is important. And as Professor Rajan was telling, I also don't go for the Siemens technique. It is actually absolute technique, but somehow our UG training is in such a way that they focus on Siemens technique. Actually, the Siemens described by Das also is wrong. Siemens is the middle finger over the external ring. It is wrong. Actually, what Hamilton Bailey has written is the middle finger over the direct hernial site. So if you keep your middle finger on the external ring, it won't, even if it is indirect, need not come. So it is an absolute technique. I don't do Siemens. Then there was controversy about Bailey. The mid-inguinal point is the one which is used for the deep ring, whereas Bailey says it is between the anterior superior iliac spine and the pubic tubercle, which is wrong. So even the latest edition, the surface marking for deep ring is given wrongly. Now regarding the Hasselbalch's, the pectineal line, I'm not very sure, but what is more important is to know the anatomy of the myopectineal orifice of Fratza, because all the hernias are there in the myopectineal orifice. So the candidate should know the boundaries of the myopectineal orifice. Then direct hernia is always acquired and it is very, very rare in women. Now regarding the fifth point is regarding the theory of hernia, congenital, acquired, etc. The acquired is the collagen deficiency which was mentioned. That is called the metastatic emphysema of Reed. That is the terminology, metastatic emphysema of Reed. The collagen deficiency is called metastatic emphysema of Reed. Then coming to the classification, the student should know at least one or two classifications. I think the European Hernia Society classification is good. At least NIHAS is a very good classification. For practical purposes, NIHAS is good. So they should know at least one or two classifications. Now, eighth point I would like to mention is they should know, be thorough with the anatomy of the inguinal canal. And they should know at least one tissue repair. Even though we talk about laparoscopy hernia surgery, the student should know as a postgraduate a good tissue repair. Of course, nowadays we do the Liechtenstein tension-free repair, but now new tissue repairs are coming like Dasada or even Schultes. They should know. Suppose he is forced to do or work in a place where mesh is not available, you should know one tissue repair, which he should be able to do. Now the complications of hernia surgery, complications of hernia was discussed. Complications of hernia surgery, the student should know, especially 2-3 things. One is inguinodynia. that is the involvement of the sensory nerves, the ilioinguinal nerve neuralgia and genitofemoral neuralgia. These two neuralgias they should know. And also ischemic orchitis. Ischemic orchitis is due to thrombosis of the papilliform plexus, and that will occur if the surgeon is separating the sac from the cord with peanut or something and injuring the papilliform plexus. So you are not supposed to injure the papilliform plexus. And also in complete hernia, never dissect beyond the pubic tubercle. If you go beyond pubic tubercle, it will produce scrotal edema. So never ever go beyond the pubic tubercle. And while keeping the mesh, it was discussed, you should go 1 centimeter beyond the medial to pubic tubercle. Otherwise, that is an area of recurrence. So the mesh should go beyond 1 centimeter of the pubic tubercle. Never take bite from the pubic tubercle. That will produce osteitis pubis. So that also the candidate should know. Then the ischemic orchitis will present as swollen spermatic cord, swollen epididymis, and testis. The moment somebody is having the testicular swelling or edema, one should suspect ischemic orchitis. Now, as Satish Prabhu was mentioning, they should know something about mesh. It is called lightweight, heavyweight, and medium weight meshes. And the different types of meshes they should know. And then, of course, we talk about lap hernia. Even though nowadays those who are doing laparoscopy will say that lap hernia is the gold standard, but at least they should know the indication. Bilateral hernia, recurrent hernia, femoral hernia, lap hernia is the ideal. So these are some of the points which I would request the students to read about in hernia. Of course, hernia is a big topic. I have been to Gilbert, and Gilbert, he will start talking about hernia from morning and he will go until midnight. Wherever we go to the dinner, he will talk about the history of hernia, the technique of hernia, all those things. And think of hernia as a daycare surgery, because always we think of anesthesia and lap surgery. But remember that under local anesthesia in Gilbert's Hospital in Florida and also in Shoulders Hospital, they are doing only under local anesthesia. They do it under local anesthesia. They give some, show some exercises to the thigh and knee, and the patient is out of the table. They will walk and then they will drive home. So such a simple thing we are doing under general anesthesia, and or spinal anesthesia is miserable with retention of urine, and then the patient will be in the hospital for 3-4 days. It is unnecessary. So the student should know one tissue repair, maybe Lichtenstein tension free repair or some other tissue repair. Now they are coming out with the DASADA. The results are even Western literature is coming regarding good results of DASADA also. He is an Indian surgeon, but good technique. So I think with that much information regarding hernia, once again, I congratulate our Professor Srinivasan, Professor Sharat Chandra, and Satish Prabhu, Mohammad Salim, and all the examiners, panel of examiners. And I take once again this opportunity to congratulate the Calicut team under the leadership of Professor E.V. Gopi. Now also I should thank Professor Rajan. He was also attending all the sessions. Thank you very much.
Thank you very much for giving the opportunity, sir. Whenever given, I will join, sir.
Thank you very much for giving the opportunity, sir. It was a
Gopi sir, Rajan sir, Babu sir. Nice to see you.
Highlighting session we had. We enjoyed this session. Thank you, Gopi sir. Thank you, Dayanand Babu sir. Thank you, Rajan
Thank
sir.
you.
Thank
Thank
you,
you.
Srinivasan. Thank you, Satish Prabhu sir. Thank you.
One question. Do you have Califest?
Yes, sir. We have one announcement. We are going to conduct the CME, ASA CME next month, February 27th and 28th, Saturday and Sunday. And this is online. And
Last
I
time
also
Califest was my last conference. After that, Corona.
because of Corona, this year we are not conducting CME, ASA CME.
Even Madurai is not there, sir. Babu sir, we used to see at Madurai.
Yeah. I'm missing really Madurai.
Madurai, sir.
Yeah.
Madurai is not there. Califest is not there. Okay, sir. 27th and 28th.
We can declare the prices on the CME of ASA.
Yeah,
Okay. Yeah.
That is February 27th and 28th.
Yeah, we will declare on those days.
3 p.m. to 6 p.m. Only short cases and scenario. Not completely planned, but up to that.
What is the timing?
3 p.m. to 6 p.m. 2 days.
2 days. Okay, nice.
Only online. Otherwise, people will not attend.
Right.
Kindly send the invitation, sir.
Thank you, Srinivas sir, and
Thank you,
sir, Satish Prabhu.
Thank you, sir.
And answer once more. Thank you very much.
Good night, sir. Good night,
Good
sir.
night. Good night. Thank you, sir.
Thank you all. Good night.
Sir. Good night.
Good night. Good night, Babu
Good
sir.
night. Good night. Good night. Good night. Good night.
Bye.
Sir,